because there are so many people who are surrounding me who are trying to take selfies. Hello people, so nice of you all to be here. This is the inaugural session of the evidence-based education system book which I am going to publish. It is going to be published on the 15th of this month. So let's go through that journey. But before that, who am I? There are two parts of that question. The first question is what I like more, and second is what is my academic side. So let me tell you about who am I. This here is me with a mic, and I am always there. Wherever mic is there, wherever it is available, I am always there. This here is me smiling brightly because there are so many people who are surrounding me who are trying to take selfies with me. This is me, my real self, because that is what I always am with my computer, and that is what I do throughout the day. This is what I love most. I give lectures, give presentations. That is what this is all about. This is me taking a webinar. The smile on my face shows that I have not worn my trouser, and that is why that particular smile is there. And this is me in my private practice. So this is all me. So let us see my academic side. I have been in academics for more than 33 years. I have been principal dean of two colleges, been a keynote speaker and orator for many conferences, both national and international. I have conducted workshops basically on evidence-based practice, 3D printing and faculty development. I have been a research guide with several dissertations done under my mentorship. I have been an educationist throughout, and that is why I am more interested in newer technologies in education. I basically focus on learning technologies rather than on teaching technologies. I promote many innovations which come in. Every innovation which come in, I am probably one of the chief members to try it out and show it to our colleagues. I am currently doing development of accreditation standard for clinics. The book has 5 sections, as you can see here. It is comprising of 1200 pages with 6,52,000 words written in that. So it is a very comprehensive, detailed coverage and a compilation of the thorough knowledge of evidence-based practice and curriculum. And the best part is that it has got guided example-based walkthrough techniques, and that is why even for a novice or a beginner, this is very easy to understand, and it is integrated in healthcare delivery. So students, faculty, private practitioners, all can benefit from this book. So let us have a great launching of transition of evidence-based practice into evidence-based education system. I call that EBP 2.0 because it is an upgraded and refined version, and mainly it is integrated into curriculum, which evidence-based practice as it is taught today is not integrated. What we are trying, where do we want to go reach when we launch such a book? We want to reach into the evidence-based practice 5 A's in a simplified manner. We want to understand what is the COVID situation, why we failed. We want to see how curriculum can be developed on the evidence-based process. Therapy, diagnostic, harm, causation, all this can be easily be understood and applied. Research based, so that you can understand the research in a very simplified manner, understand the statistics also, and learn how easily you can do the statistics without having to bother much about the way you are doing it. We learn about all the domains, the cognitive domain, the psychomotor domain, as well as the communication domain. We go for spiral teaching and co-teaching, experiential learning and integrated learning. And what we use is blended and problem-based learning methods, not teaching pedagogic methods, but andragogy method. And lo and behold, the book is finally unmasked. The book is futuristic in many ways than one, but at the same time it is contemporary so that it can be utilized even today and should be utilized today. It promotes equitable health care so that every patient is benefited. Patient satisfaction is the main concern. It is patient-centric in that sense, and it allows for equitable skill development of all the students so that whether the diversity is there or not, everybody learns and has the same amount of expertise. The book is into 2 volumes. The first book basically is on the evidence-based process, where the 5 A's are taken into consideration and a simple walkthrough with examples are given. Then it takes consideration of the research. Okay, what are the different types of research? What are the different research designs? And where this research can be applied, and how statistics can be used. All this matter is in a very simplified manner. Then it looks at the COVID-19 situation. What were the hits and misses? Where did we go wrong? That it explains. Then decision making, the method of decision making is then taken into consideration. How it should be done so that patient involvement also is there. Then it looks at the diagnostic principles, what is the effect of the reports which you are getting. Then it looks at therapy, how it is to be implemented so that harm and prognosis is good, harm is not there. And basically it looks at causality, so that what is the cause of the disease, so that we can go ahead and do the prevention work. The second part is on the curriculum part, and this looks at the present curriculum in the form of a situation analysis. Then it finds out what are the lacunae of that. Once it gets finds out the lacunae, the need for change becomes very apparent. So there is an entire chapter on the need for change, what should be changed. Then it looks at faculty development, because no teaching can be done without having very good faculty. So faculty development and how it should be done, that is looked into the matter. And then a template is given on which the entire curriculum can be built. And that is the beauty of this evidence-based education system, that you could have a curriculum where it is spiral in nature, that it takes the student from being a novice to an expert. For whom is this particular book? This book is basically for all healthcare purposes like medicine, dentistry, nursing, paramedical, assistants in medical, and it also basically used for education. In fact, it is the curriculum part is applicable right from preschool to higher education, and that is the beauty of this system which is there, where it has got universal applicability, and that is why this book needs to be looked into. Thus, this book tells you how evidence-based process, which we have been doing for such a long time, and the curricular process which we are doing, how this can be merged together to create the evidence-based education system. We have evolved, and with that evolution, everything has evolved with us. Healthcare has changed a lot. The progress of mankind has been very of top quality. That's why we call it a premier progress. And the quality of life has also changed. though as far as healthcare is concerned may not be the better, but it has changed a lot, and along with that the education system is also changed. If you see the evolution of healthcare system first started with Ayurveda. It was the first modality. It was philosophical in nature. It was holistic in nature. And then the Arab scholars which were there, who translated that and spread it across the world, right from Greece to the far eastern areas. So you see the development of Greece philosophy, the philosophical leaders. Then you see the Buddhist Chinese medicine, and then you also see the Islamic Unani medicine. All this has developed from Ayurveda, and today's modern medical science has basically progressed because of its innovations and technology. The first medical and surgical practice was practiced by Shushruth, and it is all documented almost from 5,000 years ago. As healthcare evolved, the earliest healthcare was in the hands of the scientists, who were basically all knowledgeable scientific people. They were experimenters, discoverers and innovators. As knowledge expanded, they separated out into chemists, physicists, medical doctors and astrophysicists and so many other branches. And this expansion has continued to take place and our branches have expanded. Both information and knowledge. Healthcare transformation is in all branches: medicine, dentistry, nursing, paramedical, assistantship, and as you can see today in the modern area, it is very technologically sound. With evolution, data increased, which led to information, which led to knowledge, and scientists they could easily keep abreast with the knowledge. When the disciplines came, things become difficult. When subtopics were there, it became still difficult. And today, in evidence-based era, it is totally impossible to be abreast of all the different discoveries which are taking place. And that is where evidence-based practice and today evidence-based education system steps in. The much needed change from evidence-based practice to EBES is now required. EBES is the new avatar, and I would call it as EBP 2.0 is what evidence-based education system stands for. Previously, we used to have general practitioners who used to be the friendly neighborhood practitioners, who knew your family, who knew everybody in your house, and who knew your lifestyle. And that is why he was a great practitioner, because there was more care and empathy from that person. Today, our degrees are all specialist based. So we have directly MD degree which you get, and then there are dual degrees where MD or MS is joined to something else. This makes the things very impersonal, organ system based, and is narrow, not holistic in nature. And because insurance comes into picture, lot of investigations are done just to be on the safe side, so that the money recovery is there. So your defensive medicine creeps into it today. For the doctors to keep abreast with all the knowledge and information which is available today is totally impossible situation. The holistic personalized treatment is needed by the patient, and which is difficult to give because of our education system, which is more on based on expertise knowledge or specific knowledge. So evidence-based education system is essential today. If you see the logos of the earlier evidence-based process, you will find either it is experience or expertise which is being promoted, and that makes the entire healthcare either faculty or student-centric and not patient-centric. The need of the hour is to be patient-centric.
And today we have started realizing that patient-centric is important. But what we have not realized is that we are not mixing curriculum with the evidence-based. So that is why the development of evidence-based education system, which will deal the 5 A's which is there of evidence-based process into a patient-centric methodology, and that is why it will be very important. Let us take a pause and see at the reviews of the evidence-based education system. The first one is Dr. Sridhar Shetty, who was the Dean and Principal of EBES MIDS College in Mangalore, Derlakatta, and he was also the past President of Dental Council of India. What he has to say is that traditional healthcare needs to be revisited. Attitude of asking why for all processes in workflow needs to be involved. The concepts and the context need to be revisited. We have the concept, but we don't take the concept. And post-COVID, that is most important. The new paradigm in curriculum would be the transformation of teaching into learning. This book is a must-read for all educators. The second review is from Dr. Shailesh Lele, a famous fellow and Deputy Medical Education of Dundee, a fellow of that particular place. What he says is that evidence-based practice is taught as a separate subject and not integrated into this thing, and that is where it is failing short. Faculty teachers end up teaching what they have been taught, so it just the tradition keeps on following one after another. Faculty is also chosen on their medical dental degree, so their teaching ability is never taken into consideration. There is always a resistance of change, lack of drive to learn and relearn, which is required if evidence-based education system is to be used. And the book is very comprehensive, enough to make the change and the transition which is required. To get back, let us go to Evidence-Based Education System Volume 1. This is the evidence-based process, the 5 A's which is there: ask, assess, appraise, apply and assess. Let us see how the book takes this into consideration. The first step is to ask the question regarding the patient. This question has to be a focus question, and it should follow the PICO rule so that the rest of the procedure follows. Now we may have various questions like why is that not everyone who smokes develop cancer? Why do some non-smokers develop periodontitis? Now these are the type of questions which are more for a background question, not a foreground question. So what we are interested in foreground question as far as evidence-based process is concerned. So what do we start with? We start with case summary, then we ask the focus question, and then we do it in the PICO format. To give you an example, let's take a case summary. My son drinks 3 Coca-Colas a day on an average. I have read that it causes dental caries and diabetes. Is it true? Now the focus question in this is, in teenagers, can 3 sodas per day likely to cause increased dental caries or initiate diabetic condition? From general summary which is there, we are going into a little more focused area, and then this is to be transformed into what is called as the PICO section. PICO stands for patient, intervention, comparison and outcome. So as far as and this question is of etiology. So here the patient is are teenagers who in intervention will be frequently drink soda compared to those who don't. That is the comparison, at risk of either diabetes or caries. This is how questioning is done. When we are searching on databases, we may need to expand or limit our search. That is basically because what happens is that some authors write as say child, the other may write as children, some people may write as young adults, or some may write it as below or 18-year-old. Now this differences which is there needs to be incorporated in that, and that is why alternate words should be there. Otherwise sometimes good references or good articles can get lost, and that is why you have to reframe your PICO including all the terms, so that you get a comprehensive search. Second part of the 5 A's is access. Now access is the search strategy, and you should always go for peer-reviewed databases and not on a simple Google search or something like that, because those are unreliable. Best thing is to use PubMed, EBSCO, Ovid, Cochrane, Scopus and similar databases. Limiting and expansion is the main criteria when we are trying to access the articles. So expanding is important, and there are various methods by which you can do it. Limiting is also very important, because you can't read 6,000 articles at a time. So you need something which is less. Now, for example, if you just write soda, then all the articles on soda will come. It is an expansion. If you write Coca-Cola, then all the articles on Coca-Cola will come. If you write caries, then all the so all these are expansion. But when you use not an X, if it is used improperly, then it causes limitation, but it is not very useful. But for example, when you write Coca-Cola and caries, you are limiting only those articles where Coca-Cola and caries both are being utilized, and only those articles come. So this is very specific. So this kind of limitation is very useful for us. So it removes all the other criteria which is there, and only focuses on what you need. Then depending on your needs, whether prevalence is there, epidemiology is there, you can add that word. If you add effects, then pathophysiology will come. And if you just like diseases, then caries and its repercussions will come into picture. This is how your expansion and limitations is done, so that you get a limited quality of 20 articles which are precise to your focus question and what is needed for your patient. Once you have expanded or reduced or limited, and then you have created at least about 20 articles of choice, you go to the next step, that is appraise. These articles need to be validated on their research methodology, critically observed for their conclusions and all, and find out whether they are statistically relevant. So is the article correct for you or not? That is to be seen. For that, there are various steps like relevance, whether it is your initial question and the article, whether the questions are similar, whether it is current, it is not an old article. What is the research question of the article and what is your research question? Is the research design appropriate? Whether bias control has been done, protocol compliance has been done or not, hypothesis has been tested or not, whether the statistics are valid and correct interpretation is done, and whether the conclusions are logical in their methodology. The next question is to review the application of that particular articles which you have selected. Whether they are related to your patient, whether they can be generalized, and whether clinical significance is also there along with statistical significance, because only statistical significance is not enough. So the studying population applicability is something which you have to see. So what is the study population? Whether this study population can be generalized to your patients, to your research which is there. Whether there is clinical applicability of those results to your patients or your clinic or your research. Whether it relates to your research, patients of your research whether the population of the study has a non-specific demography. If they have used a particular demographic conditions only, then it may not be applicable to your patient. Randomization, whether it is done. Intention to treat is most important because dropouts create a lot of statistical differences, and clinical significance will override the statistical significance every time. Of the 5 is the next A is apply. Means whatever appraisal you have done and you have selected the article, you apply that same to your patient or your research, and then you record what are the findings to further confirm that the results of that particular articles are proper. So monitoring applications to the your public, learning about the efficacy and efficiency of that should be done. So in research you'll do a pilot study before you are applying research to all your patients. A patient trial can be done if it is in your private clinic. Statistical efficacy is to be checked and whether it is easily applied. So efficiency comes with easy application. Monitoring has to be done in a very stringent manner. And what is most important is that the quality of life, whether any improvement in the quality of life, return back to the function of the patient, that is to be seen. So what we actually mean is being patient-centric. When we apply it to our patients, what we have to see is whether there is enough efficacy, there is enough efficiency, there is precision in the way in which you apply the research knowledge, and their patient satisfaction is most important. Now, the clinical efficacy is to be taken into consideration with tangible effect. Whether the patient is able to understand what progress has been made, what is the size of the effect, that is to be checked into consideration, which leads to whether the patient is satisfied or not in his own words, and whether he has recovered his own total functionality. His return to his previous lifestyle, whether it is social, in the job or with his family, that is the most important thing which we have to see, and that is what makes it patient-centric. Evidence-based education systems wants you to be correct in all respects, and that is why the results which you are getting, you have to reconsider and assess properly, and the assess is the 5th step which is there. So whether the validity is there or not, and whether any improvement has been there in the patient. So for that you need to have results parity. So your results and that results of those articles also should be comparable. The workflow should be similar, and the most importantly, reproducibility of the result and repeatability to other patients, that is the most important. Now, where do we use this process of evidence-based education system that we are trying to promote? That evidence-based research is generally utilized in the most important part of our healthcare delivery, that is creating clinical guidelines, procedure development, protocol of how to approach the patient in a given situation, and then ultimately once that is done, it is included in the textbook so that it can be utilized in education. And that is why textbook knowledge is a little old, because going through all that patient will take about 7 to 8 years. But when you use evidence-based education system, you are always current because you are doing it according to what the current research says. And that is where evidence-based education system scores, because procedure of the healthcare delivery can keep on getting improved with your continuous research. So you have to keep on generating evidence by doing more and more research. You have to use better classification than your clinico-pathological kind of or histological kind of classification, because that does not help you in either diagnosis or treatment planning. You need to create objectivity so that whatever classification you do gives you straight away what kind of treatment procedures are we looking at. And that is why you need to have a treatment classification which is there, which is more patient centric, and not the kind of classification which the insurance companies give you, where you, for a particular classification or finding, you get this much amount is paid. This limits your healthcare delivery. It is not patient centric because the patient is not benefited by that, and you are also not able to. In fact, on the other hand, it promotes defensive practice of medicine and dentistry, and a patient really doesn't get the benefits of a better healthcare delivery. So what kind of evidences are we looking at? We are looking at a very comprehensive type of evidence where the risk analysis, the diagnostic methodologies, both in the laboratory as well as in radiological, and the treatment process which is there, all these are taken into consideration, and then your evidence is created. This is what is going to take us forward. Obviously, it has been directed to the lacunae which we have. Today, many times when you go to for evidence-based process, the evidence may not be available. So it is our duty to see that that lacunae has been filled. We create better protocols, and we have an dynamic evidence-based education system. Continuous evidence generation is basically ingrained into evidence-based education process, and that is how we have a loop system where evidence creates protocol, and the protocol ultimately seeks more evidence to upgrade itself. So that continuous upgradation will improve the healthcare throughout, rather than make it static as it is today. And then we come back to the original where we started, to ask frequent question, focus questions, and PICO. This keeps on going round and round. That is what makes evidence-based education system totally upgradable on its own, be very current in its application, and is basically what patients need. Evidence-based education system is a complete circular process where the starting and the ending point is the same, and then it keeps on rotating between these two things so that the patient care is improved.
Friends, it gives me a great pleasure to introduce you to a senior academician, a pathbreaker, and my very close and dear friend, Dr. Bharat Modi, who has authored a book on evidence-based education system. Now this book comes in 2 volumes. The first volume relates to the basic information of this evidence-based education system, and the second one relates to its application in curriculum designing and execution. Initially, this education-based process was used in healthcare delivery and education. Previously, our education system had 3 important points: remembering, recall, and retrieve. Now, in this education system, working memory or the short-term memory had tremendous limitations. Dr. Modi has taken tremendous efforts to pen down his experiences in healthcare evidence-based system and to apply it in an education system. The senior academicians, education policy ministers, or the makers and the government who wish to execute this system need to study these two volumes. These two volumes should be on the racks of the library, on the tables of the education policymakers. Now this is just the beginning. Let us welcome this system with open arms. Once again, heartiest congratulations to Dr. Modi for bringing out this new change in an old age education system. Thank you.
It gives me immense pleasure to speak about Dr. Bharat Modi, my old friend and colleague, and his continuous efforts to think and to act differently. And now I want to congratulate him for his new book which has come up about the evidence-based education system. To begin with, let me confess that I have just bare minimum knowledge about evidence-based process, so that sort of disqualifies me to talk about this topic. However, I have known Bharat Modi to always think and act ahead of his or our time. For example, he took keen interest in zero radiography just when it was invented, studied about laser holography, holistic medicine, 3D imaging, CAD/CAM, in short, all the topics which I have carefully avoided in the past. Evidence-based process eliminates bias and dogmatic views of well-established and experienced clinicians, and the treatment based on evidence-based dentistry in all likelihood is the best option for the patient. It is for the experts like Dr. Bharat Modi to simplify the scientific concept and pave the way towards better research and clinical practice. I congratulate Dr. Bharat Modi for his new book on evidence-based education system and wish him all the very best for his future endeavors. Thank you.
Okay, that brings us to evidence-based education system, the volume 2, which is about curricular integration. Curricular integration cannot take place unless and until we know what is the present curriculum, what are the lacunae, what needs to change, and how the faculty development should be taken to create the change which we need to do in our education system. And that is what is ultimately given as a template for on the basis of which the entire evidence-based education system will be integrated into the curriculum. The first thing that we have to understand is that our curriculum is discipline play. We have departments based on the disciplines, so we are acting in silos. And it is neither on epidemiological base nor on the chief complaint base, because basically what happens is no patient comes and says that I have got a cyst, please treat me. He comes with a swelling and we have to teach them. Now we teach them in different disciplines. The same lesion is being taught by different disciplines, different departments, and we expect the students to assimilate all these things to put into the healthcare perspective, which is where our entire system goes wrong, because our teaching is totally disjointed, and then that creates inequity, because it is basically based on implicit curriculum and not explicit. So this is where the inequality in healthcare delivery, in healthcare education develops, because we are teaching disjointed and allowing them allowing the students or the doctors to assimilate all this on their own, in their own mind. So it is totally unguided personal skills, which is part of the implicit curriculum. And we have assumptions on that because we teach the same thing to all the students, irrespective of their disparity or diversity which is there. And what we think is that if we give them enough patience, they will develop this on their own. So this is a totally unguided method. We have what we call as competency-based curriculum, And for that, all the three domains which are there, the cognitive domain, the psychomotor and the communication domain, all this should, the skills in all this should to be taken together. We have to break down skills in such a way that each step which is there, taking the student from the novice state to expert state is having different levels and different stages, and these have to be taken and guided. If they are not doing well, they need to have a repetition of that, and that can only be done if we are using formative evaluation. Unfortunately, all our questioning, all our tests which are there are all summative in nature, and that is why taking the students along with you to gain mastery is not something which our curriculum does today, and that is why we need formative evaluation in its original sense. And that is why we need what is called as a spiral curriculum. A curriculum which takes the student from simple to complex, from a novice to an expert, in a staged, scaffolded, step by manner. That is what is needed for the curriculum to be. For example, if we are taking any disease for that manner, the spiral curriculum will first go into its epidemiology, then we'll tell you about how this disease can be reversal can be done. Primary prevention is what is then taken into consideration. Then if early disease treatment is to be done, if it is a little more advanced, then go for secondary prevention. More advanced the treatment is taken, you go for tertiary. Then comes your surgical intervention and quaternary prevention, and then comes your advanced and experiential experimental learning. These are the different stages which we need to go through if we have to take spiral curriculum. The second part of a good healthcare delivery is to be holistic in nature, taking into consideration everything, not only the disease or the lesion itself, but also to see the patient's body makeup, his constitution, the family background, the environment in which he is staying, the social media, social environment which the patient is staying in. That is most important, and that is why previously we used to have what is called as a general practitioner, but today all our courses are either MD or dual degree processes, and because of this combinations which are there, the impersonal behavior has crept into it because it is specialty based. So rather than seeing the patient, his background, his family and all, what we are seeing is reports, and according to the reports the treatment is being done, and that is where I think healthcare delivery has gone wrong. What we are missing is the family physician or friendly neighborhood physician, whether it is a medical person or whether it is dental person or the nurse which is there. And that is where the healthcare system goes wrong, because the holistic approach cannot be possible because we don't know the patient's background. So disease treatment, whole body treatment, environmental changes, lifestyle changes, all this can be possible only if the doctor knows the patient and his lifestyle, and that can be done only with of the general practitioner, and that is what is missing in our healthcare delivery. And even where general family practice is it is as a specialty and not as a friendly neighborhood practitioner. That is why to have this we need a patient-centric curriculum. The curriculum which we have is basically either faculty, what the faculty should teach, which is faculty-centered, or what skills the student should have, so student-centered. But what we need is basically healthcare delivery is about patients, and that is why patient's satisfaction is what we need to do. We are teaching them concepts, but we don't teach the students what is the context where these concepts are to be utilized, and for that purpose it should be patient centric, and that is what evidence-based education system promotes. And that is why our healthcare should be based on patient's satisfaction and how what is the outcome as far as the patient is concerned. It cannot be students' skill based approach. The general practitioner is the one who will be able to do that, and we have to focus our education in such a way that we create general practitioners rather than experts or specialists in our education. That speciality could be a second step as a post-graduation, but primarily our task is to create general practitioners who have a holistic approach, who understands the patient, his background, his lifestyle, and he can make changes in that because he knows the patient thoroughly. To instill holistic approach into our students, we need to be holistic in the way we deliver their curriculum itself, and that is why co-teaching, multidisciplinary teaching is very important. Instead of breaking it down into disciplines and the wards of those disciplines, what we need to do is having clinics which are multidisciplinary. You have one clinic where we are teaching only reversal of the disease, epidemiology of the disease, or primary prevention. Then you go to the second level where we are teaching them how to do emergency treatment and things like that, along with all the different branches coming together. The teachers should be all from each from one department, so that when they are handling a patient, they have a holistic approach to that, and that is how they learn to be integrated. And once they have the comprehensiveness and the integration, long-term learning is easily developed, and that is what an ecosystem is all about. So what we are looking at is an integrated multidisciplinary approach to creating learning within our students. So we teach anatomy in the first year, pathophysiology in the second year, surgery and medicine in the third year, and fifth year we are asking them for advanced treatment procedures. Basically this is all discipline based, separate teaching for the students, and students have to mentally merge in the form of an implicit curriculum. So co-teaching holistic approach is is something which is really required in today's healthcare system. Secondly, our teaching is pedagogic based, where the students are passively listening. The entire batch of students is listening to us, and teacher is going there and pouring the bucket of knowledge on top of that. Now, how much it is being retained in the whole in each of the members is different, which is what is creating the inequity. What we need to do is going for an andragogy. Similar teaching cannot be given when there is diversity, and for that you need separate batches and personalized, customized teaching needs. Problem-based learning also, wherever it is being taken, is done sporadically. So what we need to do is that we use andragogy. And today's students are all from Gen Z, and so they want to take everything in their own hands rather than passively listening to. So discussion, self-learning is something which we need to develop. If we want to create great doctors, then expertise and competencies needs to be really well explained. The competency should be broken down by detailing into milestones, checklists, and this checklist should be checked by the Likert scale. And this competency is not an overall skill. because we are trying to take the student from novice to expertise, irrespective of what is the diversity in the student, then we have to break it down into smaller parts. So each competency has to be broken into smaller parts. For example, in psychomotor skills, dexterity, speed, habitual nature, ergonomics, all these are different aspects which we need to, we can't just have that a person is competent enough to do this job. He has to be competent in all these different aspects. Then only that competency is developed. Evidence-based education system recognizes that each skill, for example cognitive skill, has got its different aspects. What we are basically focused is only on recall. Interpretive and problem solving is generally we expect the student to develop on their own. So we need to have a process where the student is guided and free him from recall memory, because working memory is taken over when you try to recall. So interpretation and problem solving just doesn't come into the student life. Our basic attitude is that our knowledge is broken down into data, info and knowledge. Now that having said this, we are missing the last part, that is the wisdom part. We give conceptual knowledge to the student, but we do not teach them where that concept should be utilized, that is the context of that application. So pedagogy, assessment and interaction should be based on how to develop that wisdom which is there from the data, information and knowledge which you have gained. And for that your working memory has to be, if the student has to think of where to apply it, then his working memory should be deep. And that is why the curriculum should be such that experiential episodic memory is developed so that long-term learning is possible. This is the evidence-based education system approach. How do we do this? How do we achieve this? We achieve this by using hybrid learning. You need to have blended learning, flipped classrooms, memory encapsulation methodology for at every place, whether it is at the theory lecture or whether it is at OPD, wards or any other, or in the field also. So Bloom's taxonomy based andragogy principle is to be taken into consideration so that lifelong learning develops, and that hidden curriculum needs to be developed. Hidden curriculum tells you how the workplace should be evolved so that learning takes place automatically. This is called as educational ecosystem, which evidence-based education system promotes. The present curriculum unfortunately is based on teaching and not learning, because the competency is not broken down into smaller pieces. We are only having broad-based competency. We have hands-on knowledge, having similar lectures irrespective of the diversity of the students. We have the same lecture for everybody. So it's a hand-down kind of knowledge transfer, which whether the student learning transition takes place or not is not guided at all, and that is why we need evidence-based education system. The present curriculum unfortunately is based on teaching and not learning, because the competency is not broken down into smaller pieces. We are only having broad-based competency. We have hands-on knowledge, having similar lectures irrespective of the diversity of the students. We have the same lecture for everybody. So it's a hand-down kind of knowledge transfer, which whether the student learning transition takes place or not is not guided at all, and that is why we need evidence-based education system. So what we need is an educational ecosystem, which we call it as hidden curriculum, and whatever curriculum is there from implicit to explicit is required. With the more matter which is there in implicit, the lesser is going to be the learning, or more unequal is going to be the learning. Our curriculum is syllabus based, so we are just having a list of topics which are to be taken, but it is not curriculum based, which tells you what is to be taught, why is to be taught, at what level it is to be taught, how we can transfer that knowledge into learning by the students, how to assess that. All this is part of the curriculum and not a syllabus, and unfortunately we are basically on syllabus based. Implicit curriculum should be as little as possible, and the most important thing is that we have to develop an ecosystem of learning which is called as hidden curriculum. This development is the most crucial as far as evidence-based educational system is concerned. Our present system is to give them a number of cases so that they get experience. But getting experience is not something which is planned. So what we need to do is we have to create that experience through our hidden curriculum. So we have to make students work in teams so that discussion takes place every time. We have to make them work as coordinators, and the entire patient management, instead of being taken by coordinators who are from other fields, the students themselves should be the coordinator, so they learn at every step, whether the patient is at the OPD, whether he is in the waiting room, whether he is at the lab, or whether he is in the ward. At every place, the students, when they follow that patient, they will be able to learn. So that is how an experience is created. Episodic learning is created. The memory develops for that patient, and the patient really in the true sense learns, and this is a lifetime learning. That is what evidence-based education system stands today. Which brings us back to where we started off with discipline-based practice, silo practice, which is very limited. And this is what is required to make a spiral curriculum and evidence-based education system. The presentation is only a surface scan, but the entire analysis is tip of the iceberg. The whole iceberg is below the water, and which you can access only through going through the book. So I would sincerely request all of you to read this book. The healthcare delivery and the process, both in education as well as its delivery, is an ocean where quality care is the gulf where we have to reach. And basically our old traditions of using evidence-based process as a separate subject has not worked. It has fallen down. Similarly, traditional curriculum is not up to the mark as far as going. We need to have a evidence-based education system which is a super liner and much more safer.
Thank you everybody for listening to what I had to present. This is just the tip of the iceberg. The whole thing matter is still there. A lot of it is there, and lot of will come in the future. And that is why what we need to do is we go through this book, learn what is there, adapt it, and then ultimately keep on experimenting, keep on researching, both on the educational side, both on the evidence-based side, and then try to make this a complete whole. What I have given is in this book is a template. So from that template, taking in that as a scaffold, you go ahead and start building the curriculum. It will be very easy to build a curriculum on the template which I have given, and it will be totally make our dentistry and medicine to what healthcare system which we want, and that is what it is going to get you. So please read the book and interact with me on my blog. Thank you very much.
The maxim is let us interact. Only with interaction will things can develop. I do not say that the evidence-based education system which I am promoting is the end in itself. It is just a beginning. It is a loop kind of thing. We have to keep doing more research and we have to more upgrade itself. So go through the by Google search, go through the website, go through the blog and interact in the blog with me and with other people. You can download my digital card if you want to contact me. So explore and have a very really great happy reading for all of you, and let us take this forward to have better healthcare. So huge thank you for patiently listening to me and attending this inaugural section. Let the force be with you and let us interact on the other side and have a very happy reading and happy day to you.